This is a scientific meeting, and I wanted to show you that, because we're not going to talk about the science of biology, we're going to talk about the science of psychology. But I wanted to show you that where I come from, as I can understand the sciences. So let me just tell you, out of college, I did some contract research for the National Institutes of Health. I've got my master's degree in microbiology and immunology. I've taught undergraduate bacteriology at Virginia Commonwealth University. Got my mastership in the Academy of General Dentistry because I wanted to know all the disciplines in dentistry. And I practice, and I'm a full-time practitioner, and I write, and I speak, and I coach. So today, we're going to talk about the new patient exam and what we're trying to accomplish with the new patient exam. And we know three things: that new patients are the lifeblood of the office. We know that the average new patient value is the single most important metric for practice growth. And we know that more new patients that say yes to your treatment plans means more growth. Now, the new patient exam is absolutely the most important appointment that you're ever going to have with your patient. And you can screw it up here. It's real easy to screw it up, or you can build a lifetime relationship with your patients. Now, let's just take a couple of scenarios. Let's just take a patient that calls in the office that wants to be healthy, calls in because thinking about getting their mercury removal amalgams removed, and a patient that wants to be, a different patient that wants to be beautiful, that is looking for veneers, top and bottom. So both of these patients are going to be elective patients. Both of them could be $16,000 cases. So if the dentist on the new patient exam approached them similarly, it might sound something like this. Let's take the patient who wanted to be healthy, thinking about the mercury fillings, wants that for her family, the health of her family and the health of herself. The dentist may say, listen, Jennifer, I don't know what you've been looking at on the internet, but the American Dental Association and the FDA, they have no scientific research that says you're actually going to become healthy when you get your mercury removals, fillings out of there. It says, I don't think this is something you need to do. But if you want me to, I'll put white fillings in your teeth. Now, if the same dentist took that approach with the patient that came in that wanted veneers, top and bottom, he'd say, Jennifer, I don't know what kind of bride magazines you've been looking at, but the American Dental Association has no scientific proof that you're actually going to become attractive to any generally accepted scientific parameters. This is something I don't think you need to do. But if you want me to, I'll put veneers on your teeth. Now, both patients probably aren't going to have this dentist do the work, but both of them are going to have the work done. It's elective dentistry. So the new patient exam is terribly important. It is something we all learned as dentists and as hygienists at what to do. And if I was an alien hovering over your new patient examination, and I'd say, what are we doing with your new patient examination? And nationally, the new patient average value is about $1,500 to $1,700. And an alien would take a look at that and say, what are you doing with the new patient exam? What are you trying to accomplish? And they'd take a look at you gathering data and taking x-rays and getting health histories and all of that. But the new patient exam is not the only thing that we have to be concerned with. There is a grid of 10 elements that comprise the new patient exam and appointment, and we call it the new patient grid. Now, I kind of associate that. My son is a Marine who's seen action in Afghanistan and the Sanjan Valley and fought Taliban. And he'll tell you, it's all about accomplishing the mission. So if you know your situation that you're in, he says you don't go into a situation if you don't know the grid. So this kind of made sense to me when I thought, okay, so we've got a grid here of 10 elements. And the situation with the new patient is what objective, what are we trying to do with the new patient here? This is what I see as a grid that we can follow, and it's a strategy and system analysis. So where do we start? What's the goal? What's the goal for our patient? What's the goal for our staff? What's the goal for the practice? What are we looking at? What's included in the plan? What's the end result that we're trying to look for? Because our staff needs some kind of track to run on with the new patient exam. So the new patient grid is a new way of looking at your new patient exam, and it's going to suddenly create some breakthroughs and some advantages that you didn't see before. So I'm going to go through that today. There's 5 steps in the formula. First step is the opportunity that we have. The second step is the conversation that we might have. The third step is the discovery of what's going on with the patient. The third step is the proposal that we have for treatment. And the fifth step is the agreement we have with the patient. So there's 10 elements and 5 steps into the new patient grid. So it basically means this. You want to find out what your patient wants, influence your patient in a positive way, in an ethical manner, to help that patient perceive the need for your care, accept what you're saying, and move forward with your best option biocompatible care. So this is the new patient grid, and it has 10 elements to complete it. The first opportunity that we have is the first patient exposure, the initial phone call, the first office, first impressions. The second is the conversation. That is the introductions of the staff, the introductions of the doctor with the patient. The third is examination, diagnosis, and treatment plan. That's the discovery of what you're doing. The fourth is case presentation. Now it's going to be called the proposal, and I'll tell you why very shortly. I do not like case presentation. And the final agreement, where we see financial arrangements and scheduling treatment for the patient. So the opportunity is your first and only chance to make that good impression. And it's going to be your signage. It's going to be your phone calls. It's going to be your in-office greeting. It's going to be the smell of the office and the attitude of your staff and your paperwork that you have to fill out and the comfort of your chairs and the sounds that are coming from all of your office. That's the first opportunity that you have to impress upon the patient. The conversation is a way to communicate. And I'm going to spend a lot of time on the conversation today because I think it's something that we need to build a long-term relationship with the patient that we never did get. But I'm going to tell you all about it because it is the communication of at a level that the patient can understand. Because if you're not talking on the same level, you're not getting your information through. The patient is not understanding. So when each one of us makes a decision, we take into account all the trusted sources that we've ever known, and it gets filtered through our subconscious. And we analyze those facts and come to some kind of a conclusion that makes it right for ourselves. And then, yes, let's do that. We're convinced. But that means that we trust what we say to ourselves. In other words, we believe what we say to ourselves much more than we believe that what anybody else says to us. So, in the new patient exam, how do we know what that new patient is thinking? Well, if we planted a few seeds that grew during the new patient exam, we could figure out what the patient's thinking because we put it there. And you'll see that in just a minute. So, what I want you to do is talk to the patient in the language of the patient about what matters to the patient. Because your information is only as valuable as the patient thinks it is. So, the discovery. This is the part that always makes sense to us. We gather all the clinical records, all the clinical data that we've always done. And right now we're looking at the patient's health rather than just their teeth. The 7 diagnostic disciplines are the periodontal disease concerns, the restorative concerns with biocompatible materials, cosmetic and orthodontics concerns, temporomandibular disorders, occlusal disease concerns, sleep apnea, pathology, and infections. And I won't go through the 7 diagnostic disciplines specifically at this time, but this is, whole body dentistry is starting to get a lot of press. And it's in part because of Peter Dawson. He just recently published that the oral systemic connection is revolutionizing dentistry. So they're starting to get on the same page that we are. And so it's been my thoughts that discoveries in science, and that's why we're here at a scientific meeting, discoveries in science and innovation, and that's what you're going to learn today, is the innovative part, are redirecting the evolution to include whole body health and create new value. Now, the creation of this new value is for improved health of the patient and increased performance of the practice. So, that is the discovery. The proposal. This is more of case presentation. But this is a holdover from dental school when we call it case presentation. And I never did like it. Never did like the words case presentation. I hated when I had to present the case to anybody. I'd fidget with my pencil and my hair and my pants legs, and it was like the antithesis of confidence, and I dreaded it. But this is where you explain to the patient how you're going to fix their teeth, treat their gum disease, and figure out how you're going to get them to say yes. So, in dental school, this is what we learned. And we brought it over into our private practices as case presentation. And I'm going to give you another idea, an innovative way to turn that around in your practices. So you sit, this is in dental school, you sit with the patient, item by item, line item, go over the treatment plan. The dental school thinking was to convince the patient to our way of thinking. Formalize the plan, tooth by tooth, memorize it, present it to the patient to gain their acceptance. Now, in academia, this is what it was. You have a specific steps to follow. The students were taught about, were never taught about emotions and justifications for price and trust. So case presentation to me always meant this. I associated with like a cold case, like that's not going to be solved. I'm right up against a case that I cannot do anything with. Or I thought about it, okay, what if you're going to litigate a case? It's like, on the docket, number B4952. Or the presentation. I always think of some guy in a suit, in a white, doing a presentation. And there's people out there, but they've got no interaction about what's going on with the presentation. This is how I always thought presentation was. I hated it. So the proposal is different. It's where you propose solutions that fit into the wants, needs, and desires of your new patient. We'll go into that. Now, the agreement is the last thing. And that is where you've got your only chance to make a good, lasting impression. And this is it. This is how you're going to get the patient, how the patient is going to be treated in your office, how the patient is going to schedule in your office, how the patient is going to be on time in your office, and how the patient is going to pay promptly and in full. Those are the agreements that I want you to have. And that is the 5-step formula for the new patient grid. So I want to cover the conversation right now. The conversation is a series of 10 questions that is designed to start the patient thinking about not money, not time, not pain. I want them to only think about need and urgency, because need trumps time and urgency trumps money every single time. So they have to see the need and the urgency for themselves. And you cannot instill or create a pressing problem in someone else's mind. You can only awaken one that's already there. That's what this is designed to do. So everyone is driven by their own self-interests, and we buy things that are aligned with our self-interests. And it's very easy to take actions on things that we think about and think that we have initiated. Your treatment plan will be accepted if it's the new patient's idea in the first place. Now, they've been convinced by somebody they already trust, and that's themselves, and you'll see how this comes about. Now, the conversation revolves around a series of questions that finds out where the patient wants to be, find out where they are right now, and lead them toward the steps to take to achieve the goals that they've got for themselves. Now, this helps them see a bridge to take from where they are to where they want to be, but where do they want to be? You haven't asked any questions. You don't know where the patient wants to be. I was just in a coaching client's office in Sacramento, and their first new patient examination is the patient comes in, fills out paperwork, goes and gets x-rays, goes and gets a Panorex, and all the other records, photographs, and they haven't asked the patient one thing on what do you want out of your dentistry today? So there is a series of top 10 new patient questions. The patient will, they tell you what they want, and you tell them how to get there with the least amount of problems for the rest of their life. And you'll see how this comes about, because we'll go through it right now. Now, the setup is this. The clinical assistant introduces you to the new patient. Now, a long time ago, I always thought it was appropriate to go into the new patient, and they'd say, you know, Susan's my clinical assistant, and Susan say, you know, hey, Mrs. Creason, this is Dr. Evans, and introduce the patient to me. I want that to turn around. So now, when I go into my new patient, Sue says, Dr. Evans, this is Cheryl Creason. She's our new patient. And it's not about me. Like, I walk into the room like, okay, here I am. You know, things can start now, right? I'm here. It's more like you walk in and see an old friend and you say, oh, there you are, you know? So can you see the difference immediately? So that sets up the next thing is where you do not pick up the mirror and explore. That's what we think we start with. I want you not to consider that right now. I want you to pick up a pen. I want you to ask the top 10 new questions to the patient. I want you to listen, and I want you to write. Now, in this stage of the internet, email, instant news, everything says speed has become an expectation. But trust takes time. So if you think that you're going to run right through a new patient examination as fast as you can, the trust factor is going to be lessened when you do that. So you just can't say, trust me, to a new patient and have it. It's not like there's a 7-step thing to trust. You follow the 7 steps and bingo, you get trust, obviously. So the 10 new questions, 10 top 10 new patient questions are, and we'll cover each one of these in short time. How can I help you? What kind of dentist are you looking for? Have you ever had any bad experiences at the dentist? What makes a good dentist? What would you like to accomplish? Will you be interested in short-term, long-term solutions? Are you going to do something? You'll see what that is. This is where you'll be able to deviate to the patient's best interests. Are you going to do something? What's going to get in your way of getting the work done? Does this seem like an effective plan? And would you like me to help implement the plan? So those are the 10 questions, and I'll pick them apart for you right now, and you'll see psychologically how this builds one upon the other, so you don't ever have to do a case presentation again. You'll just propose treatment for the acceptance. So Jennifer, you're at the dentist today. Now, as soon as Sue says, you know, Dr. Evans, this is Cheryl Creason. She's our new patient. And I'll shake her hand, and I've got a chair there. I usually don't sit in my operatory chair. I've got another chair in the operatory to make it comfortable. I say, Cheryl, how are you? She said, you're at the dentist today. You know, how can I help? And sometimes I'll take a pause in between there because it's got to be conversational. And I say, you're at the dentist today. And because there's a good reason why I say that, because some people hate going to the dentist. And they want to know, they'll roll their eyes. I said, hey, you're at the dentist today. And I said, how can I help you? But it lets them know, at least you know that it could be a very awkward situation for the new patient to be at the dentist. So, how can I help you? They're going to tell you, and this is what you need to do for the patient. They say, well, I'm here. I've seen you online. I've got a lot of mercury in my mouth. I'm thinking about getting it out. Or you've got a new patient that says, hey, I've got insurance and need my teeth cleaned. Or somebody who hadn't been to the dentist in 10 years. But what they tell you right here is what you need to do for the patient. Now, when you sit and ask a question, how many dentists have they ever been to that sat down and asked them a question immediately and instead of just start taking the x-rays or start taking photographs? So you're kind of setting yourself up as being a little bit different immediately. Now, the second question, once they tell me what they want, which is 20 seconds to 2 minutes sometimes, I ask them, so what kind of dentist are you looking for? And this is something else that sets them back a little bit because they think all dentists are alike. So now you think, okay, they're going to tell you why they're in the office. Well, I was looking online. I was looking for more of a holistic biological dentist. Or they say, hey, I'm just here to get my teeth cleaned. I mean, they're going to tell you why they're in your office today. So now you know who you're dealing with and why and what to do for the patient. So if the patient thinks that all dentists are alike, you're going to kind of say, well, no, we're all not alike here. So what kind of dentist are you looking for? So the third question. You've kind of got to this third question by just asking specific questions. But this question is more of a conversational piece. It's not, have you had any bad experiences at the dentist? It almost should come off as, have you ever had any bad experiences at the dentist? And they go, oh, God, yes. If I had any when I was a kid, I had no Novocaine, they did, or, old Mrs. Bailey says, when I was young, my dentist used to do. Or that's my dentist over there. That's what I think of my dentist. Or, you don't know what their experiences were. What's the bad experience at the dentist? But what it does, it allows you to be compassionate. It allows you to be on their side. It lets them vent any bad experiences because you're going to play off this immediately right now. And you say, well, so what makes a good dentist? In your eyes, Cheryl, what makes a good dentist? And she's going to tell you, I never thought about that before. Nobody's ever asked me that before. Well, somebody who's knowledgeable, somebody who's painless, somebody who's caring, and they'll tell you the things you need to exemplify to be the dentist. This tells you who you need to be for this dentist. Painless, knowledgeable, honest, listens to them. But what I normally do if somebody says somebody that's knowledgeable, somebody who's painless, somebody who is caring, I'll turn to Sue sometimes and say, if it's appropriate, I'll say, oh, no, Sue, we were doing so good up until that honest thing, and that always gets a chuckle out of the patient. And the barriers start to break down at that time. And you can just see just relaxation of the patient because now you've got a couple of other things going for you. Because I'll say, oh, man, I was doing so good until that last part where we got to be honest, and it's obviously crazy for the patient and it just breaks them up a little bit. But immediately after that, I'm going to tell them, I said, listen, Cheryl, you're in a very good office. You'll have my best skill and attention. But it shows that you're fun, you're agreeable, you're confident, but it also lets them kind of think. So what do they want in a dentist to begin with? So this is a sheet of paper, and I don't have a link that you can get to this, but I will give you a link. And I don't even have a piece of paper to go around on, but if you give me your email address, I'll give you a link where you can download this. This is just a cheat sheet worksheet that I have for myself that has the 10 questions on it, plus a couple of other things, and I'll show you that right now. Up until that, have you ever had any bad experiences with the dentist and what makes a good dentist in your eyes? Once they tell me what makes a good dentist, I'll ask, have you got any mercury fillings? Have you got composite resins in there? Have you got crown and bridge? Have you got any root canals? Have you ever had any extractions? Do you have any partials? Any oral surgery? Any cosmetics? Any braces? Any implants? Any perioscales? Any periosurgery? Have your mercuries been removed already? Any full mouth x-rays? Any night guards? Do you snore? Any problems with pain around your ears? I'm going to cover very, very quickly, right after question number 4. And also on my cheat sheet up there, you say, any problems with cavities, any problems with gum disease that you know about right now, any sensitivity of teeth? Do your teeth fit together? Do you think your teeth fit together okay? I am going through the 7 diagnostic disciplines. I want them to know I'm going to be looking at composite resins. I'm going to look at cavities. I'm going to look at fillings, bone disease, gum disease, how your bite works, oral cancer screen. I'm going to be looking at all of these things because they've had to answer each one of those. I want to know if you snore. I want to know how we can improve and help your whole body health. So one of these questions right down there, I kind of want to know, have you had regular care or sporadic care your whole life long? And they'll answer that. And while they're answering that, I will ask the first of my under the radar questions. And even before they've stopped answering, do you snore? Oh yeah, my husband stuffs me all the time, and that's going to be important for the 7 diagnostic disciplines in my treatment plan. And then before I write that down and write that check off, before I even raise my head, I ask them, how long are you going to live? And they say, excuse me? I said, how long are you going to live? I said, oh gosh, when the Lord takes me, or, my grandmother lived to 94, and I ask her, is she old? And she says, no, my grandmother's not. She's still cooking pretty good at 94. So you kind of think this person's got good genes. And it's a pattern interrupt that I'm looking for right here. I want to stop them in their tracks when they say, excuse me, how old am I going to be? Well, if they're going to be 94, are you going to keep your teeth? And always, 100% of the time, they say, I plan to. Duh. Well, now you have permission to think long-range goals and create a treatment plan that addresses everything, all right? That's what I get out of rushing through everything about what they have in their mouth. I also want to know what kind of dentistry have they purchased in the past. And then the verbal skill comes up, says, Jennifer, if it's all right with you, I'm going to create that plan with you to ensure that you have your health and your teeth in good shape with the least amount of problems when you're 94. Now, is that going to be okay with you? Now, can you see what just happened? Are you struck by a new thought? I hope a light bulb, because now you are a trusted advisor because you have her permission. Because you don't give advice to somebody who hasn't asked for it. But now you also have permission to create a treatment plan with all the 7 diagnostic disciplines and create whole body health dentistry and keep her teeth when she's 94. So this is the seed of hope that you're doing. Now, you have just created a situation where Jennifer has just agreed and given you permission to generate the treatment plan with her that helps her keep her teeth and be as healthy as possible to be 94 years old with the least amount of problems. That is the grid, because you don't go in a situation and not know the grid. So right now, you and Jennifer are clear on the situation and the objective to develop a plan for health. That's the ticket right there. That's the ticket. And it was Jennifer's idea to begin with. So immediately right after that, I bolster that by asking the 5th question. So, in our work together, what would you like to accomplish then? What will your goals be? Now, that's a strange question, and it's not easy to say if you just want to say it right away, because it's awkward. But what it does is, in parts, it says, in our work together. What does that already mean? It's kind of presumptuous, isn't it? It's like, okay, we're working together now on your health. So in our work together, what would you like to accomplish? What will your goals be? So she's already said, yes, let's look at a good plan for my health. So now I want to know, what are your goals? Well, I want my mercury out. And then I've noticed this wear on my teeth, and we'll take a look at that. I did have a night guard a long time ago, but I don't use it anymore. And you just run through all the things that you went, and you did the 7 diagnostic disciplines right after question number 4. So when that happens, again, this is what you need to do for the patient when she says, what do you want to accomplish? What will your goals be? This is positive expectations that you're planting for the patient. So this kind of sets a little roadblock up for the patient. I want to kind of purposely put a bottleneck up for her. So, so if I find a problem during the exam, will you be interested in short-term or long-term solutions? And it should be long-term solutions. Now, there's going to be short-term things you have to do. You need to buy a water pick. You're going to have to test for the biocompatibility of the materials that you're going to be using maybe. But there's going to be short-term stuff. But you want to confirm that she is on the right plan that says, I like long-term solutions for myself. You may notice that these questions are kind of like, I'm looking for a yes, a yes, a yes, a yes. And if they're going to commit to something, that you want them to be consistent with that commitment. And the more times they're consistent with that commitment, saying yes, they will not back off from that. So this is where the patient's thinking is, in the present or the future. So if you've got a patient that says, I'm just here to get my teeth cleaned, my insurance is going to run out in 2 months, I just need to get my teeth cleaned. You know where the patient's thinking is. Not every patient's a biocompatible patient. But that just sent in the reinforcements to think, yes, I'm looking for long-term solutions. I'm going to be 94. I want my teeth. I want to be as healthy as I can. So, question number 7 is the one I told you. You kind of have to come back to that under the radar area, and you want to use their first concerns here. So it's something that shows up in the conversation under question number 4 in that area of the cheat sheet. And like I said, I'll get you that cheat sheet. Just write down your email and give it to me. I'll send you the link where you can have this. And you can adjust it to your own verbal skills also. But some of the questions that might come up right here, it might be, are you concerned with the cracks in your teeth and how your teeth are wearing down? Like maybe she's got occlusal disease and you can see. Does the inflammation in your body caused by your gum disease give you any reason for concern? Are you going to keep your mercury fillings? Whatever the patient has said is her primary chief complaint, her main concern, this is where you're going to question her. What are you going to do about it? Are you going to keep those mercury fillings? Are you going to get your gum disease treated? This tells you how interested the patient is in the current health issues that they have. And are they consistent with their previous commitment of being healthy when they're 94? So it just follows one right after the other. This is a sense of urgency. Question number 8, another roadblock I want to put up, says, what's going to get in your way of successfully getting what you're telling me you want? Now, this is another awkward delivery. But again, it's broken down. The psychology behind these words is important. So what will get in your way? Some people don't want things in their way, so you're challenging them. What will get in your way of successfully getting, because everybody wants to be successful, of what you're telling me you want? So it's not my decision anymore. You're telling me you want this. I'll help you out. But what's going to get in your way of successfully getting what you're telling me you want? And you say, well, money. So, okay, we got to, you get care credit, you find ways to make things affordable, but this is where you want to find that out. It's not an objection that you need to overcome. You just need to handle that objection because they're committed to 94 years old and being healthy. This tells you when to start treatment. We can start right now. If you make it affordable, I want the mercury out. I want it done now. So now you've planted the seeds that grow into conversations to speak to the fact that you are a different dentist. You're asking questions. You've taken 5 minutes, maybe more, but 5 minutes to 10 minutes. You are understanding. You are fun and agreeable. You've created positive expectations. You're offering hope to the patient. You're stressing urgency. And now you're very knowledgeable and very smart. And there's 2 huge points here. People do business with people they like. And the more you let the new patient talk, the more they like you. Now, studies have shown that, that in a conversation, if you talk to somebody at length, you like that person more because you've been able to express your views. You've been able to talk. But because that person has allowed you to speak, you like that person more. So that's exactly what this said. The studies have shown and proved this, is that let the new patient talk, and the more you let them talk, the more they like you. And they like to do business with people they like. Okay, you see the psychology coming underneath all of these questions. Now, people buy from people they trust, and when someone feels like you understand them, they will soon feel that you have the answers. And when you've got the answers, that's what they're looking for. So far, we've uncovered why the new patient is in your office, what the new patient wants, who you need to be for this patient. I mean, what do you need to exemplify? When the new patient wants to start treatment, how the new patient wants to be treated, where the new patient's thinking is, and you want to find out what the patient wants, influence your patient in a positive way, do it in an ethical manner to help the patient perceive the need for your care, accept what you're saying, and move forward with your best option, biocompatible care. Now, it's at this time, after question number 7 and 8, that you can start with your diagnostic records. You can pick up the Mirror and Explorer now, because you have everything, you have all of the intelligence you need to create a treatment plan after this that takes the patient to 94 with the least amount of problems. So, if the case is under $2,000, you can set the patient up, talk to the patient about your findings immediately, and provide the solution that the patient wants. So, question 9 comes up is, does this seem like an effective plan to you? You don't want to run in and try to figure out somebody doesn't want your help. Because if you've done your job with thinking about these top 10 new questions, they are already convinced by somebody they like and trust, and that's themselves. But now you kind of freeze up because, oh my gosh, now you got to ask them to sign on the dotted line. You got to sell the case. You've got to ask them to agree. You've got to close the sale. I mean, you know, now it's time, and all you have to do is say, does this seem like an effective plan to you? And again, you want a yes answer. If there's not a yes answer, all you have to do is go back to question number 7 and find out what the objection was that you need to handle. So this confirms the patient's perception of your ability and willingness to help them, and it shows the patient's level of trust in you. So the last question, instead of asking for the sale, it's very simple. It said, would you like me to help you implement the plan going forward? Very simple. Would you like some help? And again, this just verifies the patient's level of trust and cooperation in you. So, the top 10 new patient questions are all designed specifically in order to take the patient from where they are to where they want to be, show them that bridge to take the right steps to accomplish their goals. Now, all of this is kind of based in a bit of science, but it's the science of psychology so much. But many, didn't get to this way overnight. This has taken a number of years to kind of develop this with all of the education that I've had. And I've had friends that have said, and this was important at one point in time, it's 5-10 years ago. I had a friend, Dominic, told me about an instance. He went to see a new physician, and the physician was writing down the things that Dominic told him. And he was so impressed that he thought, what I'm saying is important enough for the doctor to write it down. He from that point on, he felt like, I'm being taken care of here. this is a good thing for me. I like this guy. So it's instances like that when you put yourself in the patient's position and go through these questions. It's like an epiphany to some patients when they say, yeah, this is I can do this. So that's the sheet. It's just my cheat sheet. It has all the 10 questions and some of the under the radar questions, and on the bottom it's just some clinical things that I want to know about also. But you have uncovered what the patient wants and why they're in the office in the first place, and how the patient wants to be treated, and when the patient wants to start, and where the patient's thinking is future or present, the qualities you need to exemplify, and the bridge from where they are now to where they want to be with your absolute best biocompatible care. And it's done simply in probably about 5 to 10 minutes. So it has to start with the opportunity, the conversation, the discovery, the proposal, and the agreement. And I answer any questions because I ran through that fairly quickly. I don't know what time it is, but no, we're good on time. So this carries with it a lot of differences in offices, because the office in Sacramento that I just came from is a 4-doctor office with 25 staff members, and it's terribly difficult. But in a single office like mine with 5 staff members, it's very easy to take a new patient exam and spend 5 or 10 minutes to find this out, because instead of the office in Sacramento, it's like 150 new patients a month. And the average new patient value, that most critical metric that I told you about, is about $2,100, a little bit above average. But in an office that is smaller, that can take on a strategy like a systems analysis of the new patient experience, now what I call the grid, you can raise your average new patient value so much more than the national average. So has anybody calculated that? Raise your hand if you know your average new patient value. Is good. 1? All right, everyone should know that number. It could range from anywhere from $1,000 to $10,000. And it depends on how hard you have to work. If you've got a $10,000 new patient average value, you only need 10 new patients a month, not 150. So this is the strategy that gets you there with the least amount of problems. Okay. I'll stop there. Any questions? Yeah, it probably would be. I'm sure it's on there. Yeah. And go get that, and you can just change it to yourself. I wouldn't change the wording drastically, nor the order. Do not change the order, because it's sequential as it goes right on down. It is so effortless and conversational as it goes right on down. And ultimately, Jennifer is saying, yeah, that's a plan that I can do. So it's her idea in the first place. Can I yell it out? I do that actually while I'm running through, what makes a good dentist. I'll just kind of page through that, because you know, if they've got Lyme disease, or they've had heart attacks and strokes or Hashimoto's or something, you need to know that. So I do that while I'm asking questions, literally. Kind of do it all at once. Anything else? Well, I will be available right here for the next few minutes if anybody does have any questions, and I thank you for your attention.